Thank you, everyone. I want to thank the organizers of the Champions for Change Summit for inviting me to speak today to you on understanding blood transfusions. I have no conflicts of interest to disclose, and our learning objectives for today are to explain the common triggers for blood product transfusion, detail the infectious and non-infectious risks of transfusion, and discuss some blood donor qualifications. So today, I'm going to talk about the blood products that are commonly available for transfusion. And we have four main blood products that are commonly found in blood banks throughout the United States. But before I go into those specific blood products, I want to mention a little bit about the history of transfusion. And the first recorded successful blood transfusion occurred in England in 1665, and it was not in humans, but in dogs. So Dr. Richard Lower kept dogs alive by transfusing them from blood with other dogs. And then just 2 years later, there were two physicians in 1667, one was in France and one was in England. They reported the first successful transfusions, and it was from lambs to humans. So unfortunately, or fortunately, transfusing blood from animals to humans was prohibited within 10 years after that because of reactions that were occurring. The first successful transfusion of human blood to another human was performed in 1818, so quite a bit later, and it was by Dr. James Blundell. He transfused a patient who was actually having a postpartum hemorrhage. And in this case, he used the patient's own husband as the donor, but only 4 ounces of blood was transfused to the patient. And it was done using a syringe, as blood component bags and even bottles were not available at that point. So that was the beginning of transfusions. And today we have component therapy that is commonly used. So red blood cells, plasma, platelets, and cryoprecipitate, with less commonly used in the United States is whole blood. So red blood cells are the main blood product you're going to hear about and that you might have been transfused yourself. So they are typically collected via whole blood donation at the donor centers. There's another way that donors can provide red blood cells, and that's through apheresis collections. And we'll talk a little bit about that when we get to platelets. But for the most part, red blood cells come from whole blood donations. Donors in the US can donate whole blood every 8 weeks if it's through whole blood donation or apheresis. So male donors need a hemoglobin of 13 grams per deciliter, and female donors need a hemoglobin of 12.5 deciliters to qualify as an allogeneic blood donor. That means you're donating blood to another person, not yourself. So red blood cells provide oxygen. They're stored for up to 42 days once they're collected from the donor, and they're stored at 1 to 6 degrees Celsius in our refrigerators. Transfusions of red blood cells must be ABO compatible. That's why you need a type and screen or type and cross match before you transfuse red blood cells. If someone is in the hospital or in the emergency room and needs red blood cells before we can do a type and screen, so before we can figure out your ABO type and perform a current antibody screen, we have to give you emergency release products, so universal donor products. And the universal donor red cell type is group O. And you would receive group O Rh positive or group O Rh negative red blood cells depending on the patient's age, the patient's sex, and the inventory that is available at the time. So red blood cells are transfused for symptoms of anemia. And typically, patients don't have symptoms until their hemoglobin drops below 7 grams per deciliter in a stable patient or 8 grams per deciliter in a bleeding patient. Red blood cells are also transfused during massive hemorrhage. And it's worth noting that a normal hemoglobin value in healthy adults is somewhere between 13.7 and 17.5 grams per deciliter. And that value is going to vary a little bit according to whatever lab is doing the testing, because every lab has their own reference range. Now, plasma is a little bit different. Plasma provides coagulation factors. And plasma, again, like red blood cells, is processed from whole blood collections or apheresis. Plasma is frozen within 8 to 24 hours of collection, and it's stored frozen. At -18 degrees Celsius, a frozen bag of plasma can last for up to a year. So that's the expiration date, is a year, as long as it's kept frozen. Transfusions of plasma should be ABO compatible. And plasma contains multiple coagulation factors. So plasma is transfused to a bleeding patient or one who's facing a hemostatic challenge. That means they're facing like a procedure or labor or a C-section, any kind of a surgery. So plasma is transfused when the patients have multiple factor deficiencies, so multiple coagulation factor deficiencies. We also transfuse plasma to patients that require massive transfusion of red blood cells due to life-threatening hemorrhage. Now, plasma, once it was thawed from a frozen state, it was stored in the refrigerator. So once we thaw plasma, if we don't use it right away, we put it in the refrigerator just like the red blood cells. So 1 to 6 degrees is the temperature at which thawed plasma is stored. Platelets, which are another product that help with clotting, they're stored a little bit differently than any other blood product. So they are stored for a maximum of 5 days once they're collected from donors, and they're stored at room temperature with gentle agitation. So the image you see on the screen is a platelet incubator, and the platelets are lied down flat on each of these shelves, and the whole incubator actually has those shelves that rock back and forth gently. So it's gentle agitation. Now, because of the room temperature storage, platelets are at the highest risk of bacterial contamination than any of the other blood products. And because of that, that's why they're only good for a maximum of 5 days. Now, some blood centers store them for 7 days because they have, they're using different bags from different it's different suppliers that are validated for 7 days, but the vast majority of blood donors or blood transfusion facilities in the United States store platelets for 5 days. So frequently they are subject to shortages. So you may hear of platelet donors needed. You may hear calls for platelet donations, and that's because that 5-day shelf life means we are frequently having platelet shortages. Now, typically we transfuse platelets when a patient is bleeding if their count drops below 50,000 or during a massive hemorrhage when we're transfusing numerous red blood cells and plasma units. So usually if we're transfusing a lot of red cells, we're going to match that roughly either 2 to 1 or 1 to 1 with plasma units along with an apheresis platelet. And we'll talk about what that means. If a patient is not bleeding though, you may know patients that are in the hospital for long periods of time because they have like cancer, for instance. If a patient is an inpatient and they're not bleeding, but they are not making a lot of platelets because of their illness or their treatment for their illness, we transfuse those patients when their platelet count drops to less than 10,000. But if a patient is an outpatient, again, and they're not bleeding, we typically have a higher threshold because they're outside of the hospital. They're further away from their next transfusion. So we transfuse them when their count drops below 20,000. And keep in mind, a normal platelet count can vary between roughly 150,000 to 400,000. Okay, again, it's going to vary slightly according to whatever lab is doing the testing and what their reference range is based on their population. This is worth noting that there are different thresholds in existence for placing epidural and spinal anesthesia. So if a patient comes in to deliver or to have either a vaginal delivery or a C-section, and they have low platelet counts, so say they've been pregnant and throughout the pregnancy they've had low platelet counts, they may be visited by anesthesia prior to placing the epidural or spinal, and they may tell you we can't put the epidural or we cannot do the spinal because the platelet count is too low. And the threshold varies depending on the institution and the anesthesia providers at that institution. So some places I've seen use a platelet count of 50,000 and others want 75,000 or 100,000 before they will feel comfortable placing an epidural or a spinal. And another thing that goes into that, it's not just the platelet count, it's the reason that someone has a low platelet count. So there's certain disorders that put patients at risk of not responding appropriately to platelet transfusion. So if your anesthesia provider doesn't feel like you're going to hold on to those platelets, like let's say your platelet count is 50,000 and we transfuse you a bag of platelets, your platelet count should jump from 50,000 to 80,000 or even 110,000. But if you have proven in the past that you don't respond appropriately, anesthesia might not feel that it's safe to give you an epidural or spinal. So that's just something to keep in mind. If someone has a low platelet count during the pregnancy, there's a chance that you won't qualify for an epidural or a spinal, and that's because of potential risk of bleeding. They don't want you to bleed in your spine. So this right here is an image of an apheresis platelet. So apheresis collections are different than whole blood collections. So donors are hooked up to apheresis instruments at the donor center, and whole blood is extracted and processed in this instrument by centrifugation so that red blood cells are returned back to the donor, so that only platelets and plasma are actually taken out, like a set amount of platelets and plasma, and the red cells are returned to the donor. Roughly 80% of platelets in the United States, even potentially slightly higher, are apheresis collected platelets. And it's nice because it's not pooled from numerous donors. It's a single donor produces a product that goes to a patient. So you're not pooling like 5 or 6 donors into a product. The donation takes 1 to 2 hours. So the donation, the time of the donor takes more time. So it's more of an investment that the donor is putting into the process, because it takes 1 to 2 hours for that apheresis instrumentation to do the collection and processing. The good thing about apheresis collections is that donors can donate twice a week, up to 24 times a year. Whereas whole blood donations, donors can donate only 1 time every 8 weeks. So platelet donors can donate a lot more products per year than whole blood donors. So that's good. Cryoprecipitate is another product. So this is the 4th most commonly transfused product, and it helps with clotting, just like platelets and plasma. This product contains fibrinogen and then some other coagulation factors such as factor 8, factor 13, von Willebrand factor, and fibronectin. And the only way to produce cryoprecipitate is from plasma. So frozen plasma is placed in the refrigerator at the donor center, and it is slowly thawed, in the refrigerator. So it's a slow thaw, and cryoprecipitate is a solid portion of the plasma that precipitates out during the process. So an adult dose of cryo is pooled actually from 10 whole blood donations. So 10 separate donors or 2 pools of 5 donors are issued as 1 adult dose. The cryo is then refrozen. So once the pooling of the cryo is done from 10 donors, the product again is frozen and stored frozen solid, like frozen plasma. It can be stored up to a year frozen. Once you thaw cryoprecipitate, though, you only have 6 hours in which to use it. And if it's not used within 6 hours, you can't refreeze it. You just have to discard it. So there's a potential for high wastage rates. And the normally cryoprecipitate is issued to a bleeding patient or someone who, again, is facing a hemostatic challenge, such as a surgery or labor or some kind of invasive procedure. And it's a fibrinogen supplement, basically. That's why we issue cryo, is to replace fibrinogen. And normal fibrinogen values are between 180 and 400 milligrams per deciliter, but that is in a non-pregnant person. Pregnant people have a higher level of fibrinogen. So your fibrinogen level rises with pregnancy. So while normal threshold for transfusing cryoprecipitate is about 100 to 150 milligrams per deciliter, in a pregnant person, it's higher. So it should be around 200 to 250. That's the point where your provider should feel like, I think I need to increase the patient's fibrinogen with cryoprecipitate. So there's a higher threshold. So if you get to a fibrinogen of 100 when you're laboring or during a C-section, that's very low. That's super critically low. Okay, so your levels are higher when you're pregnant. This is just the information showing the shelf life in a chart form for all 4 of the major types of blood products. So red blood cells, AS, that means additive solution. So most of the red cells in the United States are stored in additive solution. It allows them to be stored for 42 days at 1 to 6 degrees, so in our blood bank refrigerators. Whereas platelets are stored at 20 to 24 degrees C with gentle agitation for 5 days, the vast majority of blood banks. FFP and cryo, when frozen at minus 18 degrees, can be stored up to 1 year, frozen solid. And when we thaw plasma, we can store it in the refrigerator for 5 days. When we thaw cryo, it's only good for 6 hours at 1 to 6 degrees Celsius. So for the next section, I want to talk about transfusion complications. And there's a vast array of complications that can occur when someone's getting transfused blood product. From transfusion reactions that are immune and non-immune, and then transfusion-transmitted diseases. And the transfusion-transmitted diseases is typically what patients worry most about, but actually it's far less common than some other complications. So the type of transfusion reaction that is the most feared among blood bank physicians everywhere, your clinicians everywhere, is acute hemolytic reaction. So this is the type of reaction that you hear about in the news when someone gets the wrong blood type. So this is why our testing is so rigorous, and our sampling, when we take a sample from a patient, this is why the labeling is so important, because if we make a mistake, this can happen. And this is the worst outcome possible when someone's getting transfused, is an acute hemolytic reaction. Luckily, it's extremely uncommon. So 1 reaction in 25,000 transfusion episodes. And I would like to knock on wood because I've never had one of these happen. I don't want to. They're terrible. And what happens is you have destruction of the transfused red cells bearing a foreign antigen by recipient antibodies directed against that antigen. So this is what would happen if someone is group A, so you're A positive, and for some reason you get transfused B positive red cells. This is the type of reaction you would have, an acute hemolytic reaction. The first sign typically is fever. So this is why when someone is getting a transfusion, your vital signs are taken prior to the transfusion starting, then after the first 15 minutes, and then, roughly 15 to 30 minutes after that, because we're worried. Fever can be the first sign of an acute hemolytic reaction. Most of the time when we see fever, it is something else. It is something much more benign, but we worry. That's why whenever there's a fever, your transfusion is stopped and we have to evaluate you. Patients can also have back pain, renal failure, and death is, of course, the worst outcome. Other anecdotal signs that people have had when they've had the wrong blood type infused into themselves is a feeling of doom. So if anyone ever has that sensation that something's wrong when a blood product is being transfused, call your nurse right away, because that's an anecdotal sign that it's a wrong blood. This would be the sign. So of a hemolytic reaction. So once you have a reaction, the transfusion is stopped right away, and we ask for a new sample. We have a new blood sample. We do a centrifugation step, and what your blood should look like, once we separate the red cells from the plasma, it should be nice and clear. This should be, it's like a yellowish color. This is what a normal non-hemolysis type sample would show. But if you have a sample that's red or the color of Coca-Cola, that's hemolysis. So that's what we don't want. And you won't see this when they're drawing it from you. This is after we centrifuge the specimen. So we would see this in the lab. This is why if someone has a history of transfusions or pregnancy, they have the potential for making an antibody. And sometimes those antibodies decrease in titer over time, and they're not picked up by the blood bank if you go to a different blood bank. So what we do when we identify antibodies in patients is we send them a card. So this is just my hospital's version of an antibody card. So when we identify an antibody in a patient, we make a little card with their antibody, as this patient right here is a group O positive person who has an anti-big E antibody. We send this wallet card to the patient along with a letter explaining what it means to the patient and to their primary care physician. And we want the patient to keep that card in their wallet with them so that if they go to another hospital, they can just show this card, and then that blood bank will know, they'll have our information and they can call and confirm it with us, because there's no universal system in the United States for sharing antibody history. Okay, so it's important if anyone has an antibody, a red cell antibody, that they share it with new doctors so it's known in your medical record. Because that will help prevent hemolytic reactions. Other transfusion reactions, and these are much, much, much more common, are febrile non-hemolytic transfusion reactions, and they are due to recipient white blood cell antibodies to antigens in the blood product. And basically when this happens is someone is receiving a transfusion, and when the nurse takes your vital signs, you have a fever, so they stop the transfusion. They stop the transfusion and they send us a new blood specimen, and we evaluate it for hemolysis. And if there's no hemolysis, we look and try to figure out, were you having a fever before? Do you have any other reason for a fever? And if not, it may be a febrile non-hemolytic reaction. So it's a diagnosis of exclusion once we exclude all other causes of fever. Allergic transfusion reactions are the most common. So hives and itchiness when you're getting transfused. So if someone develops hives and itchiness and that's it, the nurse or whoever's at your bedside should stop the transfusion and give you an antihistamine. So something like Benadryl or Claritin. And if your hives and itchiness go away, that transfusion can be restarted, actually. And if you have one allergic reaction, that means there's something in the plasma, so some plasma protein that your body just doesn't like. And you may never have another allergic reaction again. So one reaction doesn't mean you're going to have more. And it's not associated with hemolysis. Now, if patients are frequently transfused, they may be at different hospitals, and different hospitals have different, physicians, and some of them may want to give you Tylenol and Benadryl before every transfusion. And we don't encourage that because studies have shown that that's not helpful. So there's studies proving that acetaminophen, or just showing that acetaminophen and diphenhydramine, that's Tylenol and Benadryl, don't prevent reactions. So Benadryl we know is good at stopping allergic reactions once you're having one, but it doesn't prevent them from happening. And then Tylenol, it's not really going to prevent a fever. So if you're at, an outpatient clinic or an inpatient and you're getting a blood product transfusion and you notice them saying, we're going to give you Tylenol and Benadryl, you can ask them why. Say, do I need this? You may want it, and that's your choice, but Benadryl can sedate patients, and if patients require a lot of transfusions, they may be getting Benadryl around the clock because of these transfusions, and it's hurting your quality of life if you're that, sedated constantly because of a theory that it'll prevent a reaction when we know it doesn't happen. We know it doesn't do that. So basically, I would ask your doctor anytime that you see that someone is going to give you Tylenol or Benadryl before a transfusion, ask the question, do I need this? Do you think it'll help me? And if they say, well, I don't know, maybe, then it's up to you and with your doctor to decide if you want it or not. So some other transfusion reactions that are far less common, thankfully, include transfusion-related acute lung injury. That's when someone has difficulty breathing, either within the first 2 hours of a transfusion or the first 2 hours after completion of a transfusion. And it has to be within 6 hours of the transfusion to be called transfusion-related acute lung injury. It's due to antibodies in the product reacting with white cell antibodies in the recipient. So this is something that has reduced in incidence over time because of steps the donor centers have taken. So transfusion-related acute lung injury can require patients to need supplemental oxygen via face mask and even mechanical ventilation in severe cases. Another respiratory type reaction is more common, and we call it TACO, but it's transfusion-associated circulatory overload. And in 2010, for instance, it was the second most common cause of transfusion-related mortality reported to the Food and Drug Administration. So it's a commonly occurring entity that is still underreported to blood banks. So we know that it occurs at least in 1 to 400 transfusions, but it's more common than that. We just know they're not reported because we catch them in other ways. When we're doing investigations of other reactions and we look into patients' charts, we see people mentioning TACO or needing diuretics after a transfusion. Symptoms of this include shortness of breath, so dyspnea, high blood pressure or hypertension, and oxygen desaturation. So basically, TACO is just too much fluid for your body to absorb, to tolerate. So it can happen. Usually it happens when people are receiving a lot of blood products or when people have like congestive heart failure or kidney problems. But if you're getting a lot of fluids in an IV just to hydrate you, and then you also get some red blood cells or plasma or platelets, it's an accumulation of all the fluids you're getting versus what you're peeing out. So it's a balance. And if you're not peeing out enough, you may have signs of TACO and you may need a diuretic like a Lasix to let you pee out the fluid. Okay. Otherwise, it may be hard to breathe. You may have like wheezing and crackles. The doctor may listen to your lungs and hear crackles. So that would be a sign you may need a diuretic to help you pee out all the fluid that was running through your IV, including the blood products. So management, if it's happening during a transfusion, would be stopping the transfusion, treating the symptoms such as with oxygen, Lasix, like a diuretic, and repositioning the patient, having them sit up. And then if no improvement, more diuretic, so more Lasix to pee out the fluid. In terms of transfusion-transmitted infections, the risk of acquiring a virus through transfusion is far, far lower than the risk of having a bacterially contaminated unit, which is also very low. So that's good news. The risk for hepatitis C virus being transfusion transmitted is 1 in 1 million transfusions. And the window period, so the period at which a donor is infectious, but all of their screening tests are negative still, is 1 week. So it takes a week before someone is infected with Hep C and the screening test being positive. Okay, so a donor being positive. So 1 week. The risk for HIV is 1 in 1 to 1 in 1.5 million with a window period of 7 to 10 days. And the risk for hepatitis B virus is 1 in 1 million with a longer window period of 3 to 4 weeks. Okay. The risk for a septic transfusion reaction, so a transfusion reaction because of bacteria causing sepsis in the patient is 1 in 75,000 platelet transfusions. And it's most common in the platelets, remember, because they're stored at room temperature. And this is just an article I bring up when I talk about transfusion-transmitted infections because it's so unusual. So this is a case report, I believe from Oklahoma, and it was reported in the New England Journal of Medicine in 2002. Salmonella sepsis caused by a platelet transfusion from a donor with a pet snake. So it seems like bizarre. Like, how would this happen? So a donor donated a platelet, an apheresis platelet, and it was split. So there was enough platelets collected that they could make 2 separate bags. So 2 different people got a platelet from one donation. One of the 2 patients who got a platelet from this donor died. And the donor was a 47-year-old man. And it was a man who had donated over 50 blood products in the past. And what happened is he became asymptomatically bacteremic with Salmonella enterica. And it was from handling his 9-foot pet boa constrictor. So he was petting and handling his boa constrictor, and somehow this bacteria got in his bloodstream. And when he went to donate platelets, it contaminated, the salmonella was in his blood and it contaminated the bag of platelets. So they actually proved that it was from the snake because, I don't know why, but they took a stool sample from the snake and it had the same type of salmonella that the donor ended up having in his blood and that the patient had because they did a blood culture on the patient before the patient died. So that's an unusual event. I haven't seen another one of those happen. Usually it's skin bugs that cause sepsis in platelet cases of platelets associated sepsis. And it's from not properly cleaning the antecubital fossa at the donor center. So that's why they do it very systematically. So when you go to donate red cells or platelets, they have a very specific way of cleaning your antecubital fossa before they place the IV to collect your product, because they want to make sure that they do a good job cleaning it. Because if they don't, they might have, it's typically a staph or a strep. That's the bacteria that causes sepsis in platelets. And then in terms of red blood cells, it's bacteria that like the cold, because red cells are stored in the cold in the refrigerator. So it's a bug like Yersinia enterocolitica. So that would be a type of bug that likes the cold. So this is very rare. But I have another case to show. This is one that sort of happened near where I work because it's in Boston. This was from July 2014. Staph aureus sepsis. And this was in a triplet platelet unit. So one donor donated 3 bags. So 3 platelets went to 3 different people from one donation. So one donor had, a huge platelet count, and they were able to give the products to 3 different people. In this case, one of them went to a 29-year-old asymptomatic woman who had chronic thrombocytopenia who was 38 weeks pregnant. So she was 38 weeks pregnant. She went to clinic for an appointment, and for whatever reason, I don't know what her platelet count was because it doesn't say in the article, but they gave her a bag of platelets. During the transfusion, she developed bilateral flank pain, so pain right like where her kidneys would be, and coughing. The transfusion was stopped, and she was admitted. And she became febrile to 102.8 degrees Fahrenheit. So she was transferred to the ICU with severe sepsis. So intensive care unit, she had sepsis and needed IV antibiotics. The baby was delivered by C-section, and luckily mom and baby were discharged home in good condition, hospital day 10. So what happened in this case is the platelet that this woman received was a day 5 platelet. So it was on its last day before it was time to discard it. So typically that's what happens because platelets are short supply. So we have a lot of day 5 platelets. Before they're issued, they're always inspected by the blood bank. So the blood bank looks at them, makes sure they look okay, because they learn what a normal, healthy bag of platelets looks like. So they were issued. What happened was when this patient became sick, they cultured the patient. So they did a blood culture of the patient, and they cultured the bag. So the remnant of the bag once they stopped the transfusion, they did a culture on the bag, and Staph aureus grew. So Staph aureus grew in the bag and in the patient. So when that happens, is they find out who got the other 2 bags from that one donor. And they found that out because we track all of the donations, the donor centers, everything is labeled so we can tell who got those other 2 donations. The other 2 patients were fine, no problems. And when this happens, it gets reported to the donor center. So the donor center contacts the donor and finds out, were you okay? Were you sick? What happened? They check out the donor to see if anything was goofy with the donor. No, and it was someone who had donated many units, and it was most likely improper cleansing of the intracubital fossa. And something that people don't know, when this happens, sometimes you'll say, oh, they did a bad job of cleaning them, but sometimes it's hard to clean that area on our very dedicated donors. So when donors donate a lot of platelets, like 2 a week, up to 24 times a year, sometimes donors of platelets donate like 500 units, like they're, over a course of so many years. They're very dedicated. But what happens is their intracubital fossa, where they collect the platelet, where they put the IV, gets scarred. So it gets all scarred because they have so many apheresis needles in there. So it's hard to clean the site. So sometimes that's what happens is, it's not that the donor center did a bad job cleaning. It was hard because there's so much scarring because the donor's a good donor. So that can happen very rarely, but it can happen. So signs of a septic reaction would be, marked elevation in temperature during the transfusion, chills and rigors, hypotension, so blood pressure that drops, and shock. And then if this is suspected, the transfusionist should stop the transfusion immediately and do a blood culture on the patient and culture the remaining blood product. And then the transfusion service would notify the supplier so that they can make sure there's no other components from that donor out in, at a different hospital or the same hospital. So some other steps that donor centers do to prevent all of these infectious diseases and transfusion complications is the donor history. So they do a donor history, they do a brief physical exam, and then they do all the testing. So currently, what is this? As of September/October 2021, the donor centers in the United States are testing for hepatitis C, hepatitis B, HIV 1 and 2, HTLV, so human T-cell lymphotrophic virus 1 and 2, syphilis, West Nile virus, Chagas disease, Babesia. So Babesia is being tested just in endemic states. So I'm in Massachusetts. We're an endemic state. So all of the donor centers in Massachusetts have to test all the donors for Babesia. And then Zika virus was required to be tested until, I believe it was May of this year. So it's not tested any longer. Zika virus is no longer tested. Donors are no longer tested for Zika virus. So all of these donors, every time a donor goes to donate blood, these are tested for. Not Zika, but everything else. Everything else, every donation except for Babesia. Babesia is just in endemic states, and then Zika no longer. And then platelet products, certain platelet products, and I'll describe the ones that this isn't done for, but regular apheresis platelet products, they're cultured at the donor center. So they're always cultured after, right now it's 36 hours. And if the culture is negative after a certain time frame, then the platelets are sent to the transfusion services. So another way that donor centers try to make sure your platelets are safe from bacterial contamination is these sample diversion pouches. So when you go to donate platelets, the first 50 cc's that are collected go right into this diversion pouch. And this is where we do our infectious disease testing. So a little syringe is hooked up here so that this little first amount of blood is not in one of the bags for transfusion, just in case there's a skin plug. So when they put in that big needle, sometimes a skin plug comes out of the needle, like that's the first amount that's collected, that goes in this little diversion pouch. So that's a way to make sure if there was any bacteria or skin plug, it doesn't go into the product. It goes into this little diversion pouch. And another thing you may see is this, it's called pathogen reduction technology platelet. So this is like the way of the future, is how I describe it. So these are products, platelet products that are chemically treated in a safe way to make it even safer in terms of bacterial contamination. So what happens is at the donor center, these platelet products are infused with this little photoactive compound. It's called amoxicillin, and they are placed into this device. It looks like a flatbed scanner, like one of those old-fashioned scanners. And UVA light is shined onto the platelets. It takes about half an hour for the process. Like each bag is put into these scanning devices with UV light for 30 minutes. And what it does is it goes into the DNA of any cellular products in there. And meaning if there's any bacteria in there that have evaded detection, if there's any viruses, basically this psoralen and UV compound gets into the DNA of those bugs, the viruses, the bacteria, anything that's left in there, and it makes it so they can't replicate. So this doesn't affect the platelets because there's no DNA in a platelet. This just affects any kind of pathogen that has eluded detection or evaded detection. And so this is just a list of all the types of bugs and viruses and protozoa that this pathogen reduction technology can help keep you safe from. Okay, so it's like an extra step to make it safer in terms of platelets. So if you go to donate, you'll see this donor history questionnaire. So there's a national donor history questionnaire that was, put in place by the FDA and the AABB, and each individual donor center can adjust it and make it more restrictive. They can't make it any less restrictive, but they can make it more restrictive. And I used to work in the military years ago, and our donor history questionnaire was more restrictive, just as an example. But every time a donor goes in to donate, they have to answer these questions, the donor history questionnaire. Like, are you feeling healthy? Are you taking any medication? Have you had an immunization recently? So it's just examples. And then, have you had a blood transfusion in the past 3 months? So a lot of these questions, and there's highlights because this is from the AABB website. That's our National Blood Organization website. A lot of these restrictions have changed. They used to be 12 months and now they're 3 months. This changed in April of 2020 during the time of like the big surge of COVID. A lot of these restrictions changed from 12 months to 3 months. In general, all donors have to have a temperature less than or equal to 99.5. Male donors, as I said, have to have a hemoglobin greater than or equal to 13. Female donors, their hemoglobin has to be greater than or equal to 12.5. Donors must weigh at least 110 pounds. And then there's a medication list and an immunization list and a travel list that people have to go through with the donor center staff to make sure that you're not on any of these medications. And if you are, what the deferral is. So there's different deferral timeframes depending on what medication you are taking. And then in terms of immunizations, there's different deferrals based on the type of immunization. And some of the ones that we've gotten a lot of questions about recently is the COVID vaccine. So if anyone has had the Pfizer, Moderna, or Johnson & Johnson vaccine for COVID, there's no deferral, none at all. If someone doesn't know what immunization or what COVID shot they received, you're deferred for 2 weeks. So hopefully people know what they have. And then if you've had a flu shot, there's no deferral either. So those are like the most common ones recently. And then shingles, it depends on the type of shingle. So recombinant shingles vaccine is more common now. Did I get it? No, I know some people who've gotten it though. There's no deferral. I've gotten pneumococcal, so no deferral. But if you've gotten the live shingles vaccine, that's a 4-week deferral. Or the chickenpox vaccine, it's 4-week deferral. And then measles, mumps, and rubella, The measles and mumps part have a 2-week deferral, but rubella has 4 weeks. So if you have an MMR shot, you're deferred for 4 weeks before you can donate. There's huge lists of travel deferrals, and it's to prevent transfusion transmitted malaria. So there's, places where malaria is endemic. Donors have to be evaluated for travel to those areas, as well as variant Creutzfeldt-Jakob disease. So we want to prevent those. So the donor center staff goes through all of the places you put that you've traveled to in your lifetime, and they go through and try to figure out which places are safe in terms of malaria and variant CJD. And then the last little section here, I just wanted to kind of mention a plea for everybody to consider donating blood products if you are able to. So in the United States, donors are not paid. So donors for products that are being transfused are not paid. And the United States, and even in Canada, I have colleagues in Canada, and they are facing it similarly, that there is a nationwide blood shortage. So nationwide, especially O positive and O negative red blood cell shortage that started in June, about June 9th of this year, and it's still ongoing. So we're having a huge shortage of red blood cells, along with the new, the very frequent platelet shortages that we have. And this is all across the country. And I just found some, recently I went to some websites for Texas to look, because I know the conference is in Texas. So I looked, and there's a lot of appeals in Texas for blood products. So please donate, because there's just a critical need for blood products. And it's partially to do with COVID. So when COVID hit and all those elective surgeries were postponed during the big surge last year, the people that couldn't have these surgeries, their disease processes got worse. So it got worse, so that now, once the big surge of COVID ended, and then surgeries were happening again, more semi-elective surgeries were happening again, people were sicker. So the need for blood was like surgeries that, weren't necessarily going to use blood. We were finding that patients needed transfusions, as well as outpatient and inpatient transfusions increased. So it seems like people got sicker as they weren't able to go and get care during the COVID surge, and the need for transfusions just skyrocketed across the country. And the donations have not increased. So it's a huge problem right now. And the transfusion and blood banking community is trying to figure out how to get more donors. Because there's a risk with paying donors. So that's how it used to be. They would pay donors way back in the past, years and years and years ago, but there were more infectious disease transmissions back then. So there's risks with doing everything, basically. A risk of paying donors, and then a risk of not paying donors is you don't have a lot of donors. So we're having a big problem in the United States with being able to provide products for our patients. And sometimes elective surgeries may have to be canceled. And as a transfusion medicine director, my worry is the trauma patients and the OB patients, because it's so unpredictable, right? I want to make sure I have enough products available if I have a mother that comes in and has a Procreta. So I want to be able to support her. So I have to have a certain amount of products here kind of safe in case that happens, because we just don't know when it's going to happen. So that's my plea, is if you have never donated, consider it. And if you do donate, consider, spreading the word to your friends that it's very much needed and very much appreciated right now. So I hope today that I was able to explain the common triggers for blood product transfusion in a general sense, and detail the infectious and non-infectious risks of transfusion, and then discuss some blood donor qualifications. I could do an hour on each of these 3 sections, but that was a brief run through, and I just want to end on my youngest nephew. So this is my youngest nephew, Cole, who is a healthy baby. But I'm available to answer any questions at this point. And again, I want to thank the organizers of the Champions for Change for inviting me, and I hope this was informative in some way. Thank you very much.